All right, good morning, everyone. Welcome to the second lab quiz transmission. And today is the IVL day. I think our enemy is the calcification. So first, Dr. Zhao will introduce the case.
Good morning, everyone. This patient is a 63-year-old male whose chief complaint is paroxysmal dyspnea for 3 months. The main risk factor of his is smoking and hypertension. His echocardiogram showed an ejection fraction of 70%, marginal abnormal mellitus. The electrocardiogram showed sinus rhythm and no T wave inverted and ST segment depression. The coronary angiography showed that there was a serious stenosis in the proximal LED with severe calcification. There was a moderate stenosis in the ostium of the first diagonal branch. We also found nearly 15% stenosis exists in the middle segment of the LCS and RCA with severe calcification. The QFR of LED was 0.64. Virtual standing technique simulates the effect of the stand explantation in selected segments using predict value of the QFR. By using a QFR-based virtual standing technique, the QFR of LED may be increased from 0.64 to 0.95. It could help us to make a plan before the operation. And then we have performed a CTA scan on the patient, and the results showed that there was a severe stenosis with severe calcification in the proximal LED. In order to understand the coronary artery lesion deeply,
now I will show the intelligent visualization system for coronary CT angiography. We have shown this system for many times, and just like the audience online asked in the previous case, just like the audience online just asked in the previous case by Professor Li Yue, we think the unique technique that the intelligent visualization system for coronary CT angiography will be a useful method or weapon for the complex PCI. Now we have the aorta calcified plaque in aorta, and we can see this is a really severe calcification lesions in both the right coronary artery and left coronary artery, but the lumen in the right coronary artery is enough now, and we have the right coronary artery and its plaque enlarge the left coronary artery, and also we can see there's heavy severe calcification in circ, but if we hide the calcified plaque in circ, now we can see the lumen of circ is enough. So I think we should not do PCA or stent in the circ. Now let's hide the circ and just pay attention to the calcification in LAD. This is the AP position, and we rotate the image, and in the AP cranial, we can see the calcified plaque is from the ostium of LAD to the mid part of the LAD, and we rotate the LAD image, and we can see there's severe calcification in the LAD. In some segments is about almost 270 degrees. This is really a severe calcification lesion.
So from this image, we could see the patient has a lot of calcification, especially in LED. And in the most severely part, I think the angle is over 270 degrees. So Dr. Gong, for this severely calcified lesion, share with us your plan.
For the severe calcification lesion, as we know, the most important factor for the successful procedure is the pre-treatment strategy. The intravascular imaging is very important for selecting the optimal pre-treatment strategy. For this patient, we try to perform intravascular imaging, but unfortunately, the IVAS catheter cannot be across the lesion. We choose rotational activity to modify the calcification.
Yeah. So actually, we started this procedure much earlier. So at the very beginning, we tried to deliver the Avas catheter through the lesion, but it was it was very tight. We couldn't deliver the Avas catheter through the lesion. That's why you thought of the use of rotational atherectomy. So can show us the Avas image after the use of RA?
This is a Chinese original ELA system by Insight Life Tech. So we can see there's a Chinese windows that we can use it easily for our Chinese operator. And now we'll show the pullback. This is the distal part of the Lesion. And we can see the myocardial bridge in the distal part. And now we can see the calcified plaque in the superficial part of the plaque. We can see there's a heavy calcification is almost 300 degree. We can see there's some fracture in the superficial of the calcification. The RA is a useful method for these lesions. Now we can see the left main is healthy, and I want to ask Dr. Gong, do you want to have a provisional strategy or accurate positional? And the whole lesion length is 363 millimeter.
After the first intravascular imaging, and we performed IVL. This is the IVL balloon. We select a 3.5 millimeter IVL balloon, modified the calcification lesion. After the IVL, we performed.
Let's show the hours. Okay, this is the hours image after the IVL. And this, we have seen there's some fracture after the rotation. Now we can see the IVL. There's a bigger fracture after the IVL compared with the fracture after the rotation. And there are several fractures we can see. In the proximal part, there's also some fracture of the calcification plaque.
Based on the finding of the imaging, next we will perform stent implantation. And according to the finding of the imaging, we will implant two stents from the middle segment of LAD to the left main. The first stent.
So after the AVA strong, do you think the preparation is good enough?
Yes. Also, we will perform a pre-dilation with NC balloon. Just now, we finished the NC balloon pre-dilation with 3.0. For the proximal segment, we will use 3.5 NC balloon to get full pre-dilation and a good pre-treatment result.
So for this patient, actually the pre-treatment involves the combination of different techniques. So the rotational atherectomy first, and then after that is the IVL and the NC post-dilatation. So after all those techniques, I think we have created enough room. Now I think it's the good time to put the stents. So for the stenting, because the lesion is kind of diffused, I think there's no good spot to land the stents at the proximal LAD. That's why you want to cross circumflex, right? Two stents,
yeah,
and the second stent has to cross the circumflex.
Professor Gong, why do you choose rotatripsy but not the IVL alone?
Okay, no, because for this patient, the stenosis is very severe, and firstly, the IVAS catheter cannot be delivered. I think the IVL balloon also could not cross the lesion, so performed I firstly to dilatation the lumen in order to get the easily deliverer of the IVL balloon and cross a significant stenosis portion of the lesion.
Yeah. So right now we have more weapons to fight against calcification. If we do not have the IVL, maybe after the use of rotational atherectomy, we can use some balloon-based technologies to treat the lesion. I think it should be fine, but right now we have better techniques. Why not use it, right? That's why I think you choose the rota and lithotripsy strategy. This is a very good choice.
Yes.
So Dr. Gong, you put the first stent already, right?
Yeah. Next we will implant the second stent. The second stent is 4.0 and 28.
Did you protect the circumflex?
Yes.
You know, when we try to put the second stent, there will be overlap between these two stents. So the overlap zone should be a little bit away from the first diagonal, right?
Yes.
In the previous case, Dr. Cao Yang communicated with us the difference between the rota and the IVL. As we all know, IVL is a new weapon for us. So there's there's less article in IVL compared with the rota. So we can see, as the previous article told us, after a rota and IVL, calcified placar fractures with a much significantly greater number of fractures after IVL compared with RA. But the use of RA was associated with a greater acute lumen gain. As we all know, the rota had a debugging effect to the calcification of all kinds of plaques. But IVL just make some fractures of the calcification, but not the normal vessel or the lipid plaque. So if we want to if we want a larger acute lumen gain, we should choose the rota first. But Dr. Cao and me have tried a lot of have paid a lot of attention to the articles recently, but we cannot find that we cannot find the articles about which one is better for the minimal stent area after the stenting. So I think the further research should will tell us the results.
So both techniques, I think they have their own pros and cons. And sometimes for certain calcified lesions, maybe rota is the better choice. For some other types of lesions, the IVL is the better choice. And sometimes we have to combine these two techniques. So it really depends on the morphology of the lesion. So now we are doing IVLs after the stenting, right?
Yeah.
So Dr. Wang, can you take us through the IVLs image?
Okay, we can see the stent, and the lumen now is acceptable, but we need some post dilator. And is this the first IVLs image after the stent?
Yes.
Oh, okay.
Okay.
Okay, I think Professor Gong should choose a bigger balloon to NC balloon to do the pot.
Yeah. According to the funding, the imaging. Next, we will perform a pouch technique with the 5.0 balloon at the left main stent. After we see the stent get well a position, but in some segment, we will perform further post dilation to get optimal stent expansion. Okay, first we will perform the port technique. A little contrast. Okay.
So once we cross to the left mean, because there's a difference in terms of diameter between the left mean and the proximal RED. So after the standing, we always have to do the port in the distal left mean to get a better standing results.
Yeah.
But from the LS image, there's no like stand malposition, but only some parts is not well expanded.
So Dr. Gong, as we all know, we have more and more provisional strategy in the in PCI nowadays. So it's much easier and have a good long term term outcomes. So when we do the port technique, which position will you choose the first time you do the port technique?
And for the first port, the
Okay, got it.
The distal mark of the NC balloon will cross the main branch, and it's very important for the next kissing technique. For the second part, we also know it's named report. The distal marker of the NC balloon will locate at the distal the proximal of the bifurcation.
So after the first port, you will do the KBI, even though the ostium of the circumflex looks relatively healthy.
Yeah. The post dilation and the KBI will also performed respectively.
So what's the balloon size for the circumflex?
For the circumflex, we will choose 3.0 balloon.
So now you're trying to rewire the circumflex from the distal stent strut, right?
Yeah.
It's kind of hard to manipulate the wear.
The tape, okay. Of the tape of the Y. Maybe need a reshift.
No, it's okay.
A fine branch.